Chemistry Batch 21, a classmate of Sami Alvi. So I guess Sami gave you a lecture on history taking and examination yesterday, which comprises our first part that we call as data gathering. So today we'll discuss the other two components. One is a management plan and the other one is interpersonal skills, which are equally important. So in a structure of a case, there are 4 marks for data gathering, which are history taking and examination. That's something we discussed with all of you yesterday. The other 4 marks are for your management plan and 4 marks for your interpersonal skills. So let's just start with the management plan first. So here is what GMC wants to look in your clinical management skills. It has 3 components. One is formulating a diagnosis based on the history that you've taken and the examination that you performed or you verbalized. The second part is explaining things to patients, addressing their concerns in a way that they can understand. And the third part is formulating a detailed management plan. So let's just see, discuss the diagnosis. Okay, so the diagnosis component of our station, it's very important because when you're done with your history and your examination, you have to explain to patient what you're suspecting. And you have to explain it in simple terms that the patient can understand what is exactly going on. He can understand the severity of the condition, right? So let's just say if I'm suspecting acute appendicitis in a patient, so how will I explain it to them? I will simply tell them that from the history that you told me and from the examination that I did, I suspect you might be having inflammation of a finger-like structure in your gut, which we call as appendix. So the condition that you might be having, we call it as acute appendicitis. You can phrase it this way, or you can simply ask them, from the history and the examination that I just did, I'm suspecting you may have a condition called acute appendicitis. Have you heard of it? Patient will say, doctor, I haven't heard of it yet. So what you will need to do is you will explain it to him in simpler terms, like appendix is a simple finger-like structure in our gut. And in your case, when it is inflamed, it can cause pain, fever, and it can cause the findings that you just told me. So that is a condition we call as acute appendicitis, right? So this is a way that we explain our findings to the patients in very simple terms. And here it is really important to ask the patient if they have idea about this condition. So, okay, after telling the diagnosis, what is a management plan? A management plan is it's just a plan about the treatment options that you will agree with the patient. It's not just a one way that you will just tell the patient, I will do this, I will do this, I will do this. No, you have to agree with the patient. You have to tell them, you have to give them all the options, explain the benefits, explain the risk, and you have to convince the patient for the options, let them make the choice, right? So what components form a complete management plan? The first is you have to decide what type of management do you want to do. The second thing is the investigation that you want to have. The third thing is what symptomatic treatment that you're going to give the patient. The fourth is the specific management that you're planning for the condition. And it will vary according to the symptoms and the condition that the patient presents with. After that, if you're discharging the patient, you'll have to agree with the follow-up. And after that, you will explain to him the safety netting, that which are the red flags. If they experience, they should come back to the hospital immediately. And when you're sending them home, you'll give them leaflets so they can, we'll just discuss them in detail. Okay, so what type of management do you want to do for the patient? You have to decide done with your diet. And it depends on whether you're in GP, whether you're in the emergency, and if the patient's condition is acute, if it needs admission, if it needs referral to a specialist or to a hospital, or you can send the patient home with some medication. You have to decide at this point. Everyone, Can you please mute your mics? All right. So the next step we'll move to is the investigation that you want. And you will
मैं तो इंडिया का प्लान नहीं लाऊंगी।
everyone, can you please mute yourself? All right. So let's proceed. Okay. So in the investigation part, you will explain to the patient what test do you want to order and what are the findings that you want to see in that. You like there are three types of investigation that we usually order. There are some blood tests. It may include routine blood investigations like CBC, like renal function tests or liver function tests or the coagulation profile etc. And there must be some specific blood tests like if you're suspecting myocardial infarction, you will be ordering troponin I. In pulmonary embolism, you may order D-dimer, or like in acute pancreatitis, you may order serum amylase or serum lipase. Then there comes radiological investigations, which include X-rays, ultrasounds, or CT scan. They depend upon the patient's condition whether we need these investigations or not. Sometimes you may even ask for an X-ray during your examination component, like if a patient is presenting with symptom of severe shortness of breath, you may be suspecting pneumonia or you may be suspecting acute heart failure. You may even ask for X-ray during the examination when you are asking for bedside investigations like ECG. You may even ask for X-ray at that time, they'll give you the X-ray. Okay, so the third type of investigations include tissue investigations like biopsy, but we'll not order this investigation by ourselves. I'm just telling you in case if we are referring a patient to a specialist, we'll tell them that the specialist may do these investigations. Okay, so the next component is general symptomatic management. The symptoms for each patient might be different. Some patients may present with pain, some may present with fever or shortness of breath. You have to look at the symptoms of that patient and give the management according to that. For pain, you may give paracetamol or you may give ibuprofen mostly. But if a patient is having acute myocardial infarction, you may have to give IV morphine for the pain relief. Similarly, if a patient has fever, you will give paracetamol for antipyretic effect. If a patient has nausea or vomiting, you may have to give antiemetics for that. And if a patient is presenting with decreased oxygen saturation, he's having acute shortness of breath, you may need to give oxygen to that patient. So the next component is specific management. It will depend upon your diagnosis. Like if you're suspecting a bacterial infection, let's say if you're suspecting acute bacterial tonsillitis in a patient, you will need to prescribe oral antibiotics, which are really oral phenoxymethylpenicillin. Right, so you will tell the patient that I'll give you antibiotics for the infection that you may have to take for this much duration. Okay, so the next thing is if you are sending the patient home, if you are discharging a patient, you will need to tell the patient when you will see the patient back. Sometimes you don't even need a follow-up, so you don't need to tell the patient to come back. In some cases, you need a follow-up. Okay, so Amber, what you have asked me for, which investigation we can do on the bedside. So the investigation that you can do on the bedside include ECG, blood sugar, urine dipstick, and sometimes you can even ask for a chest X-ray. Is it clear?
Yes, it's clear.
All right. So for the follow-up, you have to decide whether the patient's condition needs a follow-up or not. And if you do not know when to call the patient for follow-up, you can simply say we'll make another appointment in 2 weeks' time. or in some cases it could be earlier, like if you're treating a patient with a sore throat, acute bacterial tonsillitis, you will give the patient antibiotics and you will tell them, okay, we'll make another appointment in 2 days to see how things are going, if your condition has improved or not, because in this case the infection may resolve in 2-3 days and you will not need follow-up for 2 weeks. So what is safety netting? Safety netting is a parameter that in NHS they use to see if you are a safe doctor. They make sure that the patient is safe at home when you are discharging them. You have to counsel the patient regarding red flags of their symptoms, so that if at any point they experience those symptoms, they should come to the hospital immediately. It's like you are just reducing the risk by explaining to patient when they should come back to the hospital immediately. The example is if a patient comes to you with a chest pain and you diagnose them to as just a musculoskeletal pain. You give them painkillers, you're sending them home, but still you want to be a safe doctor, so you'll tell them if you are experience left-sided chest pain which radiates your left arm or jaw and is associated with a shortness of breath or nausea or sweating, you should come to the hospital immediately. This is your safety netting. It will vary with the symptom. If a patient is presenting with a headache, you will have to do the safety netting for weakness in any part of the body, any stiffness of neck, any photophobia, like you're safety netting them for meningitis, for any tumor of the brain. This is what safety netting means. And also give them leaflets for their condition so they can read them at home and they can get a better idea about what condition they are having. You won't have leaflets in the cubicle when you're going for your exam, so you'll simply verbalize that I will arrange for some leaflets for you so you can read them and have a better idea of your condition. And at the end of the management plan, you will again ask the patient if there is any other concern that you have not addressed, or if there is anything particular that the patient was expecting and you could not address that. It's a very important component of your management, because sometimes we perform extremely well in our station. We perform good in our data gathering, in our examination. We explain our management very well, but we fail to address the patient's concerns. We fail to ask them their expectations, and when we get the result, we are failing that station, because this is what they were expecting from us. They wanted us to address this thing. So make it a habit that you have to keep asking the patient in between if they are understanding the treatment, if they have any concerns, any expectations, so you address them. And this sums up our management plan. If you have any questions regarding this, please raise your hands or ask them in the chat. Should we proceed to the interpersonal skills, or do you have any questions for the management plan? All right, so I suppose we should just move on. Okay, so the next very important component is interpersonal skills. Let me just briefly tell you why interpersonal skills is so important, because uh, in UK, the interpersonal skills are taken very seriously for any professional, and especially in your PLAB-2 exam. If your interpersonal skills are not good, you will not get any good marks in your data gathering. You will not get any good marks in your management, because if your interpersonal skills are not good, the patient won't tell you the complete history. He will not be comfortable and he will not agree with your management plan. So interpersonal skills are the most important component of your stations. So what does GMC want to look in your interpersonal skills? They will look for how you approach the station when you enter the cubicle. We'll just discuss everything in detail afterwards. I'm just telling you the points that we want to see. The second point is they will see how good you are at building rapport with the patient. The third thing is, do you use open-ended and closed-ended questions in your data gathering, or you're just asking closed-ended questions? Like in our cases, in our setup, we keep asking patients closed-ended questions whether you have the symptom or not, whether you experience this or not. But in PLAB-2 examination, you have to do a balance of open-ended and closed-ended questions. You have to when you approach a station, when you ask the patient about what brings it to the hospital, brings them to the hospital, they'll tell you like, doctor, I'm having headache for 2 days. So you have to ask an open-ended question first. So Mr. XYZ, whatever his name is, can you tell me more about your headache? He will tell you a few things, and then you will start with close-ended questions, right? You will ask them, for how long have you had experienced this headache, where exactly is the pain, right? These kind of questions are close-ended questions, but first you have to ask an open-ended question. Similarly, after completing history of one symptom, you will again ask them, is there anything else? Do you experience any other symptoms? If they similarly, when you're asking them about their lifestyle, you can simply tell them, okay, tell me about your lifestyle habits. Okay, tell me about your diet. So this is and this is an open-ended question. The third thing is involving patient in your consultation and ask them about their concerns. Okay. Mushpal, I'll just answer your question in a bit. Okay, so open-ended questions are like, you let the patient speak their mind. Yeah, you have to let the patient speak. You have to be a good listener in your consultation. You have to be a good listener. You have to give the patient the freedom to tell what they are feeling. So always ask the first question as an open-ended question, and then start taking history in closed-ended questions. Okay, so what is your question? If there is a patient in pain in a scenario and you offer painkiller, we just have to verbalize that I'm going to give you some medicine. You know, do we have to do something? You just have to verbalize. You will have to tell him, okay, I will arrange for to give you a painkiller. Okay, because the painkiller won't be lying at the bedside in the cubicle. You will just explain them, I will arrange to give you a painkiller. They will simply understand. Then you will take a pause for 5-6 seconds, and then you will tell them, okay, we are giving you the painkiller. It will take few seconds to start the effect. Are you okay to continue now? Is that clear, Mustafa? Okay. So we were at the point that involving patient in the consultation is really important, and addressing their concern. This is the main point of the station, because if you fail to address the concerns of the patient, you will fail the station. No matter how good you perform in your data gathering, how good you explain the management, if you fail to explain their address their concerns, address their expectations, you will fail the station. The next thing is demonstrating understanding of ethical principle. There are some ethical principles that you have read in your PLAB-1 examination, that there are certain things that you're not allowed to do. There are certain things that where you have to take a certain step. So you have to keep those in mind. Like, it is particularly important in the scenarios where LGBTQ is concerned, or where the end of life care is concerned. Okay, so there are two main things that comprise your interpersonal skills. One is your communication skills, and the second is your body language. The first thing, your communication skill, as long as your communication is concerned, there are few tips that you need to do. As you already learned grips in yesterday's session, that we do grips when we start a session. So let me just give you a recap of that. When you enter a cubicle, you will enter with a smiling face. There will be an examiner sitting in a corner, and there will be a patient sitting on a chair. You will simply smile, say hello to the examiner, tell your GMC number loudly, clearly, tell your name, and then turn toward the patient, give them a smile, sit down. This is the first step in your station. Then you will greet the patient. Hello, my name is Dr. In a good sense, like, hello, my name is Dr. Atif Anwar. I'm one of the junior doctors in this department. Whatever department you're working in, they will tell you outside the station. That is the first part of grips, right? So the next part, you will ask the patient about their introduction. Could you please confirm your full name and age for me? You can ask this way, or if you remember the patient's name and age from the outside, you can simply ask them, is it Mr. XYZ? Like you can ask this way. They'll tell you, okay, yeah, doctor, I'm whatever his name is, or they will tell you, doctor, my name is this and my age is this. Then the next thing you have to ask them is how would they like you to address them. So you will simply say, okay, so like I'll suppose I'm talking to Sami. Okay, so Mr. Sami Atik, how would you like me to address you during this consultation? He will tell you whether you should call them Sami or whether you should call them Atik. This is very important step because in UK they take these things very seriously. You have to ask the patient how would they want you to call them, right? So after that you will simply ask them, okay, so Mr. whatever name they tell you, you will take their name and ask what brings you to the hospital today or how can I help you today. This will start your case. Then you will simply take the history as somebody explained yesterday. In between, keep asking patient about their concerns, or when you're done with your history, ask the patient if there is anything in particular that they're concerned about. Is there anything in particular that they are expecting from this consultation? You can ask this at the end of your history. Okay, so the next step is body language. There is a complete video guide on GMC's website I'll find and I'll share in the group, but there are a few things that you need to keep in your mind. The first thing is your sitting posture. You'll sit in a neutral posture. There will be a chair, but you should not lean back, and you should also not lean much forward. Just sit straight. You can keep your hand. You should keep your hands open. Don't just close your hands like this. Just keep them open. You can use your hand during the consultation, like when you're explaining things, but do not use your hands excessively, and it should not like you're keeping your hands still all the time. You should use the movement of your hands to communicate things, but in a balanced way. So I'll share the video guide which will make you understand things better, because I won't be able to show that here in a very effective way. So I'll share the video in the group about the position, about how you will be sitting, about how you will be communicating. The important thing that you need to keep in your mind is you should not be monotonous. Like you're talking, okay, so what brings you to the hospital? Okay, and what symptoms were you feeling? What can I do for you? What's your lifestyle? You should not speak like this. Make sure your tone is appropriate to the situation. You should lower your tone. You should raise your tone. You should make expressions on your face. You should use your hands. And if there is any situation in the station where you may smile, that will be a good thing to do. Like if a patient tells you that they're getting married, that is a very good point to build a good rapport. So you can just simply smile. Oh, congratulations, you're getting married. That must be a very exciting thing for you. So you can use smile here. You can tell them a few things that will make them smile too. So it will build a good rapport. I hope I've made things clear, but if I have not made anything clear in this slide, you can simply ask me. Should I proceed, or is there any question on this slide? So let's just move on. Okay, so another very important thing about your PLAB-2 stations is do not be scripted, because when you attend academies, you will get the notes. When you're practicing, you simply memorize things. Many people simply memorize things, and they are speaking the same sentences every time. But in GMC, their examiners are very experienced. They're assessing like 60, 70 students every day. They know when someone is speaking the memorized sentences, and that may lead to reduction of your marks, and that may not be a good impression for your station. So please do not memorize things. Speak in your own words, speak in your own tone, speak in your own sentence. You can take some inspiration, you can take some idea about other people from other people. So for you, that since you said it's important that you make sure patients be addressed the way they want. What about gender? Since this is your concept, can you gender? So the first thing is when you're taking history, you do not need to say any he or she. You do not need to ask them about the genders at this point. There are some LGBTQ scenarios when you're reading that case. You then when you're doing LGBTQ scenarios, then you need to ask them how do they identify themselves as. In these common scenarios, in the other scenarios, you do not need to ask them about the genders, but yeah, you do need to ask them how they would like to be addressed. And one important thing is when you ask a patient about how would they like to be addressed, you have to use that name in between your consultations. Like at the first question, you may ask them, okay, Mr. Shami, can you tell me more about, can you tell me what brings you to the hospital? Similarly, you can take a brief history of his presenting symptoms and, all right, so Mr. Shami, tell me about your lifestyle. Like use their name 2 or 3 times. Similarly, when you're explaining the diagnosis, use their name. Then you're explaining the management, use the name once or twice. It helps in building a good uh, connection with the patient. So I was telling that we do not need to be scripted because many people come back from the examination, they think they performed very good, but they speak the memorized sentences, same lines, same sentences that everyone is speaking, and they fail the session because the examiners know when someone is being artificial, they are speaking the memorized sentences. Read the notes, take guidance from people, but speak them in your own words, speak them in your own tone, make it feel like it's real. The other mistake people make is they think that showing empathy means saying I'm sorry to hear that every time. No, it's not like that. Say I'm sorry to hear that when a person has suffered a loss, like when someone tells you my mother died of this condition, my brother had cancer. At that point, you need to say, oh, I'm really sorry to hear about that. That must have been very quite bothering for you, quite painful for you, or quite stressful for you. You need to lower your tone. You need to say, I'm sorry to hear that. But if someone tells you, doctor, I'm experiencing this pain for 2 weeks, you do not need to say, I'm sorry to hear that. You'll simply say, yeah, I can understand. It must have been quite bothering for you, right? So you can show empathy by lowering your tone, by acknowledging their emotions, acknowledging their suffering, but do not keep saying I'm sorry to hear that because that seems very scripted and the examiner will deduct your marks. So keep your tone changing according to the situation. Use your own sentences. Show empathy where it is needed. Do not keep showing empathy where it's not even needed, where it's not even such condition. So one important thing that I wanted to discuss is do not be close-minded when you enter a station. But like you may study your notes, you may understand that from the notes that it must be this condition. If they're telling the patient is having chest pain, you may have studied those in your case notes from the academies. But when you enter the station, always keep your mind open and go with a patient-centered approach. Go with the flow. Ask the patient about the symptoms and go with that flow. Do not make a diagnosis in your mind before starting the consultation because sometimes they come up with new stations and you're not even thinking about that condition. So you miss the diagnosis. Always keep your mind open. Trust your medical knowledge. Right. So they may give any new case, like in a headache, there were some new cases in our time. So we just went studied all the differential diagnoses, whether they had come in the previous examinations or not. We studied all the differential diagnoses, like 1 or 2 main points from those, and we did ask the patient about those symptoms, so that if it's a new case, you may diagnose that. But if you're already scripted and you already make a diagnosis before even entering the station, that may cause a trouble for you. So always go with an open mind and go with a patient-centered approach. Go where patient takes you, right? And sometimes even the diagnosis is the same, that you may think outside the session, but the patient's concerns, their expectations are different. So you have to go with those things. You have to ask the patient what concerns them, what are they expecting, and you have to address that because those are the points that will make you pass the session, and those are the points that will make you get good marks in those sessions. So this is it for today. If there are any questions,